All right. We are now at our anti-penultimate talk of the afternoon. I'm really excited for many reasons to introduce Dr. Priscilla Hsue, not just because she is an incredibly wonderful researcher, clinician, eminent cardiologist who is invested in studying cardiovascular metabolic complications of HIV at University of California, San Francisco, where she's chief of cardiology at San Francisco General Hospital, but she's now, as you already heard, coming to be chief of cardiology at my institution, UCLA, starting July 1st, so I'm super excited. But anyway, yes, congratulations, Priscilla. So Dr. Hsue is an international expert in the cardiovascular consequences of HIV infection. She began her career establishing an HIV cardiology clinic and is one of the few cardiologists around the world with both clinical and research expertise in this particular area. Her research interest is in the pathogenesis, clinical manifestations, and treatment of cardiovascular diseases and inflammation in HIV. As an investigator, Dr. Hsue leads a multidisciplinary team which encompasses a broad portfolio of clinical and translational studies on HIV-related cardiovascular diseases. She has performed clinical trials of anti-inflammatory, immunomodulatory, and lipid-lowering therapies in the setting of HIV, rheumatoid arthritis, atherosclerosis, and most recently COVID-19. Dr. Hsue has had continuous NIH funding since 2005 and is the leader on a number of NIH grants and initiatives. She's published widely in the area of HIV-related cardiovascular diseases and inflammation in all of the major journals that you would follow. She has been chair of the Clinical and Integrative Cardiovascular Science Study Section at NHLBI, is a member of the Office of AIDS Research Advisory Council at NIH, and also a member of the Scientific Committee of the Cernoff Cardiovascular Research Foundation. Currently, she oversees the Center for Excellence in Vascular Research, is an elected member of the American Society of Clinical Investigation, and is also a member of the Association of University Cardiologists, ImmunoX, and CVRI. She's had the privilege of mentoring numerous students, residents, fellows, and faculty, and has been recognized by multiple mentoring awards and grants. It's a real pleasure to have you here today, Dr. Hsue. She's going to be talking to us on hypertension and cardiometabolic issues in people with HIV. Welcome.
Thanks so much for that introduction. Way too long. I'm super embarrassed. So, well, I'm thrilled to be here speaking to you, and I'm also glad that you asked Matt, who gave the amazing talk, all the hard questions. So, hopefully, I think this will be pretty short. So, fantastic. It's interesting. I started taking statin myself. I didn't even check my LDL cholesterol because to me it doesn't matter. But I did get so I got myalgias, interestingly, because I got started on rosuvastatin at a high dose, and actually in Asians, you're supposed to start at a low dose. But long story short, it's working fine, but my biggest issue with it is I forget to take it every night. So that's because it's like the only medicine I take. So anyways, hopefully some cures for that. So thank you. These are my disclosures. I think another disclosure, I am not a pregnancy expert, but I will be talking a little bit about this in this talk. So we'll be talking a little bit about INSTIs and cardiovascular disease and HIV. We'll talk a little bit about INSTIs and hypertension in HIV prior studies, and then some hot off the press studies at Croy looking at INSTIs and pregnancy, and then INSTIs, pregnancy, and hypertension, and then INSTIs and hypertension. And I think the takeaway from this talk, I know at the end, you're going to be like, well, she didn't really say anything because she presented lots of studies for and against, and what is the data are what they are, so we'll just try to summarize them, and thank you. Okay, so this is one of the pre-activity questions. We have a 65-year-old gentleman coming to see you in clinic. He's on INSTIs, no prior CVD, but he says, I really want this advice. Will an INSTI increase my risk for cardiovascular disease? And what are you going to say to him? Yes, no, not sure. So let's think about that in the next several slides. Okay, so I would say the the studies on this started a couple years ago, and this is a study looking at a market scan database, patients with insurance in the United States who are initiating ART. And this study here found that INSTIs versus non-INSTIs were actually associated with lower cardiovascular risk. So they're somehow protective. They did all sorts of modeling, and then they also looked at this, well, what if we include another agent that has been implicated like abacavir? And they still found it was protective. So when I look at the studies and my patients, most of my patients do not have insurance, and so probably wouldn't have been included in this database, but it's kind of intriguing, but we don't really understand why. So that was one of the first studies. And this was a follow-up study that came out now 2 years ago. And this is, it's RESPOND, which is kind of DAD that is evolved. So it's a massive observational study, I think close to 30,000 individuals. And what they found here was that INSTI use was associated with cardiovascular risk more than twofold, particularly in the first 6 months. Although this, sorry, I'm gonna just shut this so I can use the pointer. Although this continued over 2 years. So they did all sorts of modeling, including like modeling for renal disease, for weight gain, for lipids, and this risk still persisted. When you looked at these individuals that used INSTIs, they did have higher traditional cardiovascular risk scores than the others. This kind of study is, of course, prone to like channeling bias and all sorts of confounders. And this study also doesn't really tell us why this is the case. I think it's a little reminiscent of some of, remember the whole abacavir story, way back when. So this finding is pretty similar to that. So I think more data is needed, really. And so last year, this Swiss cohort study came out, and I think this was, really a nice study. Now, the response study that I just presented the last slide, that included treatment experienced and naive, so they mixed them all together. So in the Swiss study, this is only naive patients, so it's a little bit cleaner. And so they looked at kind of individuals who started INSTIs and other individuals and unadjusted analysis, and then finally adjusted at the bottom. They found no difference in cardiovascular risk in persons who were on INSTI-based ART. So I think that is very interesting. So the next trial I'm going to talk about is a target trial emulation. And I thought we'd just explain a little bit about this because this is becoming more and more popular. So we know in the literature that the gold standard for testing the efficacy of an intervention will always be kind of the clinical trial, the RCT. I think, we just had this beautiful presentation on Reprieve. Those studies, they take time. I mean, they're pretty expensive. They can cost hundreds of millions of dollars. And in some cases, like during the pandemic, doing that could be somewhat unethical. And so to overcome this target trial emulation then uses observational cohort studies to try to provide some kind of evidence for interventions. And so there's all sorts of things you have to specify, like the assignment procedures, the patients who are eligible, and what's the treatment. And then you use statistical methods to model this. Of course, this kind of target trial is always, prone to confounding as well. Okay, so this next study that was published just last year in Lancet HIV looked at, large cohorts in North America and in Europe to target, to try to model this observation. And they found that initiation of integrase inhibitors was not associated with cardiovascular risk. On the top, they looked at naive individuals, and on the bottom, they looked at experienced individuals. And so they didn't find any association. Okay, so where am I leaving you in this post-activity? How do we answer this question? So I'm going to say I'm personally not sure, and I'm confused. And that's the data, that's where we are. There's many conflicting studies using different cohorts. They had different designs, different inclusion and exclusion criteria. I think just like kind of the protease inhibitor study, the abacavir study, time is going to tell this. Longer studies with longer follow-up. It takes a lot of time, as Matt alluded to develop cardiovascular disease and events. And I think perhaps when this is the case, there's going to be new HIV medication with different side effects on the horizon. So I'd now like to shift a bit to look at prior studies looking at integrase inhibitors and hypertension. Okay, we have that same patient. He's coming to see you in clinic. He's now talking about his ART regimen and blood pressure. And what are you going to tell him? The antiretroviral therapy is a big causative factor of hypertension and HIV. INSTIs are associated with hypertension because of this weight gain. What is his blood pressure goal? And is there going to be injectable blood pressure medication just like for ART? Okay. So what about the mechanism of hypertension and HIV? And I think what's interesting about this diagram is you could actually take out hypertension and put in a lot of other comorbidities, and it probably still would work. And so that is, HIV itself because of either microbial translocation, vascular effects on the endothelium, renal disease, immune issues, and also chronic inflammation. This all co-infection with other viruses like CMV, macrophage activation, this all comes together to form hypertension. I think, the ART piece, which is in this triangle, it's one part of it, but we don't know, I would say, exactly how big that part is. There's many other issues ongoing. I wanted to take a little bit of step back to look at the blood pressure guidelines, and this is, of course, in the general population. So the older guidelines, it's kind of crazy, they're 10 years ago now. They said targets, if you're older than 60, you want to hit a systolic blood pressure less than 150, a diastolic less than 90. And this is, of course, unless you have risk factors present like diabetes or CKD, then you want to hit lower targets. And I was reflecting on this when we were kind of looking at the Reprieve results. I remember early on when I started, I said, maybe we should think of HIV like a risk equivalent like diabetes with respect to primary prevention. And I think at the time, people are like, oh, that's way too aggressive, it's too much. But it is interesting, I think with time and with Reprieve, maybe we should have more aggressive primary prevention. And just like Reprieve, maybe there should be more aggressive blood pressure targets for HIV. And of course, I'm just postulating here. Then if you look at the American Heart Association guidelines, which are down here, what's interesting, they now have this category called stage 1 hypertension, and it's, systolic blood pressures in the 130s over 139. I'm gonna guesstimate that's probably 50% of people in this room. And then, however, whether or not you treat those individuals is based on their calculated risk score. And so the treatment is a little bit different. So we know that those more aggressive heart association guidelines from blood pressure are derived from the SPRINT study, and they published a follow-up of this a couple years ago. And this is, of course, aggressive blood pressure lowering to a systolic less than 120 had a significant reduction in clinical events. You can see here 27%. Of course, in order to get there, it was not free. There were more serious adverse events in this intensive treatment arm. Most individuals required more than 3 treatments. Okay, so what do we know about INSTIs and blood pressure pre-CROI? So this was a study, again, looking at the new DAD, or RESPOND cohort, and this is 30,000 individuals, big study. So in this first panel, they're looking at INSTIs versus NNRTIs. And you can see here there's a suggestion that was significant that INSTIs are more associated with hypertension than NNRTIs. However, on the right side panel, if you look at INSTIs versus protease inhibitors, you can see there's no real difference with respect to hypertension. What about switch studies? Okay, so this study looked at switch from efavirenz to dolutegravir. And I just want another side here, look at all the acronyms on this slide. So I think Dr. Sag, who I'm not sure is still here, was giving cardiologists, so like me and Matt, a hard time about all the acronyms we use in cardiology, like HFrEF, HFpEF, HFmEF. And I'm gonna just say, look at all these acronyms here. So anyways, so this study looked at ART-naive patients in South Africa who were initiating a TDF-based regimen or emtricitabine. And then in 2019, they switched from these fixed-dose combinations to a fixed-dose combination containing dolutegravir. And so they found the individuals that got the dolutegravir-based arm, they had more weight gain, and this was also associated with a higher risk of hypertension. However, other studies, and this was a study in an older, higher risk cohort in Europe, NEAT 022. These are, age over than 50, high cardiovascular risk score. Half of these patients already had hypertension. If you looked at individuals who switched from a protease inhibitor to dolutegravir, either immediately in red or delayed in blue, there's no difference at all on incidence of hypertension. And so finally, a meta-analysis published last year that tried to unpack this neatly was also kind of confusing to me. They found that a lot of the 10 studies that were published, 9 out of the 10 showed there was an increase in systolic blood pressure associated with starting ART. They weren't able to say if this was more based due to integrase inhibitors or not, and lots of variability. So that didn't answer my question. So finally, this is in that audience response question. This was a cool study published in the general population last year in New England Journal, very small, showing this injectable medication. It's an siRNA that inhibits hepatic angiotensinogen synthesis. And the single dose, you can see, is associated with significant reductions in systolic blood pressure of 22.5 millimeters of mercury in the light gray, and then the dark gray at these highest doses, around 11% reduction. And this was 6 months. So I'm thinking, like, looking in the future, what are we going to talk about in 10 years? Injectable ART medication, injectable hypertension medication, and injectable lipid lowering medication, hopefully once every 6 months or once a year. So post-activity questions, what are we going to answer our gentlemen? ART, big component of hypertension. I'm going to say false. It's part of it, but I don't think it's the most important component. Are INSTIs associated with hypertension via weight gain? Certainly that's possible, but I think studies still looking at this. What is this gentleman's blood pressure goal? So this would be correct if you're old school and you use the older guidelines. If you use the cardiology guidelines, you'd have to calculate his 10-year risk. I'm guessing it's going to be high, and you might target a little bit lower, 130/80. Injectable blood pressure medication, is this science fiction? And I'm going to say it's on the horizon. So, all right. So, I think the big question is, should we switch antiretroviral therapy for high blood pressure? And I think this is really going to be individualized on the patient. I'm going to say in most cases, no. You should not switch because of that. If needed, you should just treat the blood pressure. I think if for some reason the blood pressure is impossible to control and other ART regimens might be available, then that's something that could be discussed. But I'd say for most individuals, you would not switch just for that. Okay, so now we're going to switch to pregnancy. Okay, 33-year-old woman who's pregnant with HIV. She comes to your office. She's worried about her dolutegravir and hypertension use, and she asks you about this. So which of these following statements is true? Okay. Okay, I'm going to move on. Okay, nice. So I'm going to let you guys give the rest of the 6 slides because you like hit this spot on, which is great. Okay. Okay, so CROI updates. And these amazing slides are from Lynn Moffinson, who presented these at a WHO update. So these are fantastic. There's a lot to unpack here, and so I think the details of the studies are not essential, but just kind of the overall picture. So I think before CROI, there were a lot of mixed studies looking at hypertension in the setting of pregnancy, some showing increased risk, others not. Some recent papers showing that maybe gestational hypertension might be lower in HIV among women who are on ART before preconception, and maybe higher rates on HIV-infected women who are not on HIV medication. Then this study by Yi showing gestational hypertension was similar by ART class, however, higher in the setting of integrase inhibitors, particularly if you started later in gestation as opposed to starting earlier. And then finally, a study at the very bottom implicating TAF, potentially TAF exposure, and gestational hypertension. Okay. There are 4 abstracts looking at integrase inhibitors, ART, hypertension, pregnancy, 2 clinical trials, 2 observational studies. One trial was looking at postpartum. The other trial looked at both pregnancy and postpartum. And then, of course, the observational studies only looked at pregnancy only. And I think, of course, the issue is that observational studies were able to have an uninfected HIV comparison group, and the trials didn't have that. So, okay, the ORCID study. This is an observational study of pregnant women on dolutegravir. They were enrolled in their first trimester, and they had 6 weeks follow-up of postpartum. They took blood pressure several times and defined this as 140/90, and then they looked at incident hypertension to 6 weeks postpartum. So, okay, here, you can look at the systolic blood pressure and the diastolic blood pressure were not different between HIV-infected women and non-infected. And then here, if you looked at risk factors that were associated with incident hypertension, these were age, older age, higher BMI, and starting ART later, at later gestational age. However, there's no difference in incident hypertension between HIV-infected individuals and uninfected. What about the SEPAMO birth defect study? And so this was looking at antenatal care in births at 18 sites and taking blood pressure measurements during pregnancy. They looked at individuals on dolutegravir or efavirenz with and without HIV, and they used the standard definition of blood pressure. They looked at chronic hypertension, gestational hypertension, and severe hypertension. What did they find? Okay, in all groups, there was a similar prevalence of chronic hypertension, as shown here, between the dolutegravir arms, efavirenz, and without HIV. However, what was interesting, gestational hypertension was higher in the dolutegravir arm compared to efavirenz. So blue versus orange, but both of these were significantly lower than the HIV negative arm. So the HIV negatives have a higher rate of hypertension, which is interesting. And then finally, if you looked at severe hypertension, it was similar in the dolutegravir and the efavirenz arm, but overall, again, the uninfected individuals had higher levels of hypertension. And then when you looked at hypertension by weight category on the right-hand side, the hypertension was driven by higher weight, and it didn't really matter which regimen. So I know there's a lot on that slide, so I apologize, but just the general flavor. And so the second trial is the Dolphin 2 trial that looked at postpartum hypertension in women in South Africa and Uganda. It was a randomized study looking at women starting dolutegravir versus efavirenz at or greater than 28 weeks of gestation. They looked at hypertension in those who didn't have it at enrollment, and then they followed them up. And here you can see overall, the women in South Africa had higher BMIs, higher blood pressure compared to their Ugandan female cohorts in purple. And after accounting for, all sorts of the site, the blood pressure, there's no difference between dolutegravir ART and an association with hypertension in this cohort. There's some prior studies that are relevant. So the vested clinical trial showed that dolutegravir was better than efavirenz at delivery, and there's lower pregnancy outcomes. And they found that antepartum weight gain was significantly higher in the dolutegravir TAF regimen, although compared to dolutegravir TDF or efavirenz TDF regimen. However, this low antepartum weight gain was associated with adverse pregnancy outcomes. So in some way, the weight gain was protective. And looking 50 weeks postpartum, the women in the dolutegravir TAF arm were more likely to have higher weight. So they did a follow-up post hoc analysis of this acroid looking at blood pressure data, and they measured them, at certain time points. What's of note, they called elevated blood pressure here a systolic of 130 to 139, diastolic of 80 to 89, which is different than other studies. And they found here overall, if you look here, there was a low number of individuals that had gestational hypertension in this left-hand side. It was actually lower in the dolutegravir arm compared to efavirenz. They also looked at eclampsia, preeclampsia, and the overall numbers were really just too low to say anything. Most of the individuals who had elevated blood pressure in the study, it was just very mild, systolics of 130 to 139. They really had no cases of severe hypertension. When you looked at mild hypertension, there was a suggestion that the dolutegravir arms had more compared to efavirenz. However, if you included moderate hypertension too in this category, there was no difference between the arms. So they published a little bit of their ART and weight gain earlier this year, and they found non-significant trends for dolutegravir, TAF, FTC versus other regimens, but these did not reach significance. What's interesting is that all of these, independent of the treatment, weight was strongly associated with incident blood pressure. And so for every 5 kilogram of increased weight, this is associated with a 16 to 22% increased incident blood pressure. So overall, a high proportion of women in these studies had mildly elevated blood pressure. There are very few cases of more significant hypertension. Weight, independent of ART, was associated with increased risk of blood pressure and incident hypertension. However, in that setting, dolutegravir was associated with weight gain, and lower risk was beneficial in the setting of pregnancy. So I think a lot to unpack in all those CROI presentations. Some studies showing no association of hypertension with dolutegravir compared to an uninfected population. Another one showing higher rates during pregnancy, but overall lower compared to uninfected individuals. And of course, the RCTs, one finding no difference between hypertension and dolutegravir and efavirenz, while another one showing a possible, although non-significant. This weight gain associated with dolutegravir was protective against AE pregnancy outcomes. However, who knows whether or not it'll be associated with hypertension in the future. So I think it's great that everyone got this answer right. I'm gonna say that this is, hypertensive disorder worsened by dolutegravir use. I'm gonna say false at this time. The majority of studies starting INSTIs earlier as opposed to later is associated with higher risk. That's false, and I think most of the people got this answer right. Most of the hypertension in HIV studies in pregnancy do not really suggest an association between INSTIs use and blood pressure at this time. Okay, in the final several minutes, there were two CROI updates in the non-pregnant population, looking at HPTN 083, sorry for the typo, and the Vicen trial, so I'm almost done. So HPTN 083, HIV negative participants, this was led by Rafi, and these was men having sex with men, transgender women, looking at injectable CAB versus daily oral TDF FTC for PrEP. I want to just characterize, this was a young cohort, 75% were less than 30 years, and the weight overall in this cohort was normal. So if you look at blood pressure changes over time, systolic blood pressure on the top, diastolic on the bottom, the CAB individuals are yellow, TDF, FTC in blue. There's really you don't really see any significant big changes over here. I think that's a picture. And overall, there were around 12% of cases, or folks who were getting CAB who had incident high blood pressure versus 11% in TDF, FTC. Most were grade 2. And over 3 years of time, if they looked at unadjusted and adjusted, you can see there was no difference between CAB and TDF. It looks like the risk of developing hypertension was more in Africa, older individuals, and obese. And then finally, the Vicen trial looked at the risk of hypertension with dolutegravir versus PI. This was done in Zambia. It looked at individuals previously taking NNRTIs, 2 arms, one virally suppressed, the other one not. The non-virally suppressed included 2 protease inhibitors, along with TDF, dolutegravir, TAF, dolutegravir. So they looked at blood pressure, and at the end of the trial, they found that grade 1 hypertension was higher on individuals in the dolutegravir-based arms versus the protease inhibitor arms. And when they unpacked this a little bit more, they found that across both groups, so the suppressed, the unsuppressed, the rises in BMI were higher in the TAF dolutegravir arm compared to TDF dolutegravir, which I think is not that surprising. In the second arm, which was non-virally suppressed, the BMIs were higher in both dolutegravir arms, sorry for the typo, versus the protease inhibitor arms. This study was a bit hard to interpret because the randomization was unbalanced, and so they did present their conclusions with some caveats, and that is the risk of treatment-emergent hypertension was higher in dolutegravir versus PI-based ART, but there were some caveats to interpreting this. Okay. So with all that, I'd like to summarize, and I know I've left you a ton of unanswered questions. This is very unsatisfying. So INSTIs and cardiovascular disease. Many studies do not demonstrate this risk. Longer studies will be needed, particularly in the setting of the question of weight gain. INSTIs and hypertension. Some studies showing similar risk to PIs, others not. Hypertension and pregnancy. The study results, I think I've tried to impress upon you, are very varied. Different results of the observational RCTs. There was weight gain during pregnancy on dolutegravir, but it could be protective for the, might be protective. And then I presented some studies in CROI. RAFI study showing no increased risk with CAB versus TDF, and the Vicente study showing a higher risk of hypertension with dolutegravir. So these are just my thoughts in the last minute. I think the association of INSTIs with all of these comorbidities is still emerging, clearly. I think we know outside of HIV, the weight gain and high blood pressure, they clearly both increase cardiovascular risk, and so the association with INSTIs will be very important to delineate in the future. It's going to require, I think, more time and data to ascertain this risk. But I would say in the studies to date, they do not support switching INSTIs, for hypertension or these issues, but rather, if needed, you can treat with blood pressure medication. So with that, I'll close, and thank you.
Thanks, Priscilla. That was really a tour de force. I know, a lot of people have been machinating and scratching their head about these observations for some time, and it's really helpful to have all of the data laid plain all in one place, and your expert insights sort of laid on top of that, really helpful. So thank you for that. Question, when you sort of muse on whether or not there could be biologic plausibility to a mechanism of there being hypertension from these agents separate from weight gain and BMI, can you think of one?
I think it's impossible to separate them. And I think, actually, Matt Feinstein and I were having this discussion about the ability of statins and the benefit. Like, can you separate we know the statins lower LDL, and we know that lowering LDL is strongly correlated with clinical benefit. And so can you ever truly separate those two? And I think here it's impossible, because we know that weight increase is associated with hypertension, is associated with cardiovascular disease. So I do think it'll be very challenging to unpack that, yeah.
Great, and you've made it very clear that at this point with our understanding, the best thing you can do rather than muck around with someone's antivirals is get them on antihypertensive therapy. What are your go-to agents, and how do you think about, in someone living with HIV, the risks and benefits of the different classes? Do you just follow sort of the same pattern you would without HIV?
Yeah, that's a great question. I generally I follow the same pattern in non-HIV, and I think, there's compelling indications for each one depending on the patient. So, if the patient has mild CKD, I might consider, and/or diabetes, I might consider like an ACE inhibitor. If they have, heart failure with reduced ejection fraction, of course, beta blockers are really beneficial. If they have coronary artery disease, beta blockers are beneficial. So I think it really depends on the patient, yeah.
No, that's really great. Just thinking back to, these discussions that we've started to have, and we'll hear more about the GLP-1 receptor agonists, if they've been shown to reduce weight and we think that's the mechanism, could you imagine a clinical trial that's going to attempt to sort of look at hypertensive outcomes, as well as we saw some, early cardiovascular outcome data.
Yeah, yeah. I think that's a great point. Clearly, it was a hot topic at CROI, and I think the issue is going to be the expense, because is that something that's going to be like cheap, readily scalable, and what will happen to individuals when you stop taking those meds? And I think Dr. Srinivasan is going to tell us about that. I think similar, with these other interventions. So sure, semaglutide might be amazing at reducing cardiovascular disease, reducing inflammation, but we'll never be able to untie it because it reduces weight. So I think to me, it doesn't answer the anti-inflammation hypothesis either. But I do, I think it's a super fascinating medication. Whether it's going to be scalable to all of our persons with HIV in a readily accessible manner, I don't know. Yeah.
Yeah, no, thank you. Question here.
Hi. Several years ago, I heard you give a talk about sudden cardiac death in persons with HIV and the association. Do you have any more information on that? Is it more than an association? Any thoughts on particular causes?
Yeah, that's a fantastic question. I think some of the things that didn't make that paper, which I actually thought were most fascinating, was that we did additional analysis, I think, of those individuals that died suddenly, and we did show that markers of kind of immune activation were strongly associated. This is using nanostring kind of analysis. So those markers of immune activation, like macrophage activation, were strongly associated with increased fibrosis in the setting of HIV. So I think it provides more evidence in the field that we haven't cured HIV, it's treated, it's suppressed, but just like those individuals who have a viral load that's undetectable, there's still underlying inflammation and chronic immune activation that contributes to these comorbidities.
Thank you.
Great. While we're waiting for other questions from the audience. Oh, wait, here we have one. Do you want to talk a little bit about the contribution to cardiovascular mortality and morbidity in all populations, but including people with HIV, of cigarette smoking, and what we should be doing with regard to that modifiable risk factor?
Yeah, it's a great question. Of course, it's an important contributor, and we should be addressing it for sure. Just like blood pressure, cholesterol, diabetes, lipids, it's an important thing, and I do think it's something that's very hard to modify. Yeah.
Well, when you think about the magnitude of the effective contribution of something like that compared to starting a statin or an antihypertensive, how do you triage those things? I mean, we are a culture that likes the easy fix of the pill.
Yep.
But
Well, these are all really tough questions, and I don't think there's a right answer to that. I would say that treating blood pressure is known to be beneficial, so I think that would be high up there. Treating cigarette smoking, we also know strongly, is beneficial, particularly with this enhanced malignancy risk that is being developed, that's being demonstrated in HIV. I guess someone is asking me to ponder whether then starting a statin in lower risk persons with HIV should be a priority compared to these other these other scenarios, which I think is a really real question. And I think that would have to be individualized. I would say ideally, yes, if your patient will do all of the above, that's wonderful, but if they're only gonna do 2 out of the 3, hope I don't get in trouble for saying this, I think I would prioritize the smoking and blood pressure, especially if you have an individual who's not over 40, who doesn't have a high calculated risk. I think the cost benefit of starting that statin, the juice for the squeeze, may not be there as much as these other things. I hope that's fair.
And you're specifically saying that in people under 40,
Yes.
right? Because I wouldn't want you and Matt to get into a fight
Right.
for people over 40.
We're not
right?
going to get into
Okay.
a fight. Right.
Okay.
Yeah. Because I would lose that. He's younger than me.
Fantastic. Since we're on the topic of smoking, There's a question from the audience about whether you think about people who vape nicotine-containing products as opposed to smoking conventional cigarettes and their cardiovascular risk. Is that
Yeah.
known?
Yeah, so there still is a risk associated with vaping, and there's been a lot of kind of smaller studies looking at endothelial dysfunction, platelet reactivity, higher levels of inflammation. So I think a lot of people think it's a lot better than smoking, and just that that underlying risk is there still.
You mentioned that sort of fascinating study of the injectable siRNA antihypertensive. Are you excited about it for any mechanistic reason, or just because it's a long-acting injectable treatment that would remove adherence from the mix, or is there more than that?
I think it's both. I think it's a cool silencing RNA technology looking at angiotensinogen. So I think, if you use that in addition to other blood pressure agents that we use, like valsartan, could you have a larger bang for your buck on blood pressure? So I like it for that, because I have my patients who are on 3 different blood pressure medicines, it's still high and I can't get them down. So I like it scientifically, but I also like it, I will say, from implementation, vantage point. And that is, I think a lot of the individuals who see us in clinic, they don't like taking medications every day. And I think I could toss it back to you and say, well, why is injectable ART so hot? And it's just that, the persons with HIV probably don't like having to take medications every day. And anything that we can do, like a shot every 6 months, once a year, I think could really be a game changer.
I largely, I agree with you. I think the one area where those things differ, right, is HIV is still so much a stigmatized condition that having to take those medicines every day have that additional layer to them, whereas I don't
Totally
think
agree.
hypertension is quite as stigmatized. Yeah.
Totally agree.
Yeah,
That's spot
but
on.
no, I
Totally.
think we all are sort of musing about whether or not we're going to be having shots of everything, for the foreseeable future.
Yeah.
Right.
No, totally agree
No,
with you.
really great. So we are out of time,
Good.
but there was one more comment from the audience that I would love to hear your quick reaction to, lightning reaction. So someone said they find it really helpful in counseling people about smoking to pull up the AS-CVD calculator with and without smoking and to show people those numbers. Is that a strategy you use? Concerns
Yes.
about doing it?
No, I think that's fantastic. And the nice thing about that calculator, it not just has 10-year risk, it has lifetime risk, because a lot of for our individuals who see us in clinic, even if their 10-year risk is relatively low, their lifetime risk is going to be high. So you can really show a profound reduction, particularly in younger individuals, using that calculator. So I like that.
Amazing.
Yeah.
Thank you so much, Priscilla. That was really great.